touch on this issue of the longitudinal aspect of psychiatric illness and just like raise one point of I think support for psychiatric euthanasia, which I think is a really strong one. And this comes by way of Brent Keos, a psychiatrist and bioethicist out at the University of Utah, who has argued pretty strongly and articulately that there is a parity issue here in terms of how we think about mental illness and physical illness. I'm really sympathetic to the view that we need to treat both both sets of conditions in ways that are essentially equal, not exactly the same way, but with equality of consideration, let's just say. It's my understanding that borderline personality disorder can spontaneously remit when a person reaches their 30s or their 40s. Of course, that's a long time to wait, and we're not sure it will remit. But the idea that the symptoms around these difficult mental illnesses can become less significant over time with or without treatment seems really interesting and important because it kind of pushes us to wonder about the idea of how long one must suffer with a particular condition um, and, sacrifice in a way their own happiness and well-being for what's a possibility. And again, this I think touches on the problem of our sort of evidence base in psychiatry, which isn't as robust in, say, oncology.
Those are great points. So, starting on the parity front, with physical health, as you say, sometimes it is more reliable to make predictions about terminality with something like a metastatic cancer. Those prognoses are not always accurate, but they perhaps are, more accurate in some ways than we're able to make than for psychiatric conditions. Probably also worth mentioning, though, that there isn't always a bright line difference between a mental health condition and a physical health condition. The brain bones connected to the neck bones connected to the shin bone, that we have a tendency to decapitate people in medicine in a way by having this bright line difference. But whether it's making attributions that may ultimately be confabulations, when people have a wish to die when they have a terminal medical illness, because we might understand why somebody might want relief in that situation.
Right,
However, it is entirely possible that what's driving that separately is what we would diagnose as a mental health condition.
right,
There can be uh, physiologic reasons associated with medical illness why somebody might have a change in mood or a wish to die, whether it's carcinoid syndrome with certain tumors or paraneoplastic syndromes with other types of tumors.
mm,
There are many 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 examples here. But coming back to your latter points about prognosis and time horizons in mental illness, we are not always great about making those predictions in psychiatry. A classic example is, 100 plus years ago, Emil Kraepelin made a great contribution to the field of neuroscience when he drew the distinction between dementia praecox and manic depressive illness. Dementia praecox, what we would now think of as schizophrenia; manic depressive illness, what we would typically now call bipolar disorder. But the distinction he drew was really based upon prognosis and time course. That with dementia praecox, this is a chronic condition with decline over time and typically does not remit. And with manic depressive illness, it is episodic, and people typically would return to their baseline inter-episode.
mm,
That was an important distinction. It turns out he was also wrong in some ways on both counts,
mm,
because people with schizophrenia do recover, and many people with long-standing bipolar disorder do have some decline over time in
mm.
mental function or other function. And then, as you said, even with severe personality disorders, whether it's because of misdiagnosis, sometimes it's unfortunately used as a way to blame a patient for not responding to treatment rather than to
Right,
accept our own helplessness at not having more effective treatments to offer. or for any other number of reasons why, yes, somebody in their 30s or 40s may not look, feel, act the same way as they did when they were a teen.
So here's a tough question then, Steve. I mean, given all that, what if a person who has a serious mental illness just decides they no longer want treatment and rather have MAID or psychiatric euthanasia? In other words, maybe there is a treatment available. They just don't want it anymore or they don't want to pursue it. Should there, you think, be a requirement that individuals with serious mental illness at least try the latest treatments and maybe even say um, some treatments that are kind of off-label or experimental or investigational? What do you think about that?
That that is an interesting and hard question. You keep asking them. Uh, uh, well, let's start with just what the laws are, and these do vary a bit state by state. But typically, even if a condition leads somebody to, in a more chronic but subacute way, be at risk of harming themselves, they would
Mhm.
not be compelled to accept treatment. However, in cases of acute risk, whether to self or other, typically people can be compelled to accept treatment.
Right.
So I suppose just legally there is that distinction. But that being said, and that's sort of the hole in the fence, but beyond that, I think we generally do err on the side of autonomy in medical decision making. And just because a treatment is available doesn't mean that it's necessarily acceptable.
Mhm.
And I'll speak just personally. There are many potentially life-threatening conditions which, in some way, are treatable today, which, at least as I sit here right now, I don't think I would accept, and I
Mhm.
wouldn't want to be compelled to
Mhm.
accept treatment.
Right. Yeah, that makes sense, Steve. Yeah, I'm thinking about this notion of terminal anorexia, for example, which, by the way, is not as you know, it's not an actual diagnosis. There is no such thing. I don't think there's any psychiatric condition in the DSM that could ever be called terminal, right? And so when you hear this concept bandied about, it's a fiction, actually. What becomes terminal, when it becomes terminal, it's really about the patient deciding enough is enough. I mean, there's going to be certain physical and biological sequelae to anorexia, right, that might in fact cause a terminal condition that's physical, but the actual anorexia itself isn't well, it's a hard one, I guess, because it could very well be. I mean, this is why it's a difficult case because it does straddle this line between a psychiatric condition and a medical condition.
Exactly. It's a really interesting one for those reasons, right? It's the psychiatric diagnosis that carries the highest rates of morbidity and mortality. It is the only example I can think of where the mortality is not just associated with death by suicide, but
Mm,
as you say, potentially by the medical sequelae. It's also a really interesting example because it's probably one of the only, maybe not the only, but one of the only, and certainly stands in contrast to most medical illnesses where people who live with anorexia nervosa often aren't interested in treatment.
right, right.
It's typically referred to as being egosyntonic,
Mm.
meaning that people don't see the symptoms of the disorder as a disorder. In fact, the stronger the symptoms are, often the more successful somebody living with that condition feels. That is in strong contrast to perhaps something like depression or severe anxiety or PTSD, where somebody is actively suffering and would really want that suffering to be alleviated in some way.
So do egosyntonic psychiatric conditions, whether it's anorexia or narcissistic personality disorder, maybe, or something like that, I mean, are those by definition incapacitating? Because it seems like you just don't, if you don't have that insight, it's almost like you have anosognosia or some like denial, um, sort of in your, there's denial happening that seems like it conflicts with our basic, as we go back to the beginning, our basic model of capacity, which is an understanding and an appreciation of the condition. So is it the case that an individual with anorexia is almost by definition incapacitated when it comes to that condition?
Well, I guess it goes back to where we started with defining capacity and it being a sliding scale, right? Somebody with anorexia nervosa wouldn't blanketly lack capacity to make any medical decisions. And certainly they would most likely have capacity to make relatively non-complex decisions. But on the issue of the decision to want to die, to your point, that becomes a really, really difficult one.
Right. Yeah. Yeah. I think of anorexia and major depression. I think of these as really tough cases. I also wonder about substance use disorders and addiction and whether these will eventually be candidates for psychiatric euthanasia. If a person has just refractory treatment resistant opioid use disorder or something, would they be candidates for psychiatric euthanasia? Um,
And could they make that decision while intoxicated
and could they
or
make
while either in
or
physiological or
withdraw with
psychological withdrawal? And yeah,
right? Yeah, so I think that's an important area to keep our eyes out on because I do envision. And I've been thinking about this for a paper. In fact, this idea of sort of terminal addiction that we might hear if we hear, people attaching terminality to all kinds of mental health conditions. We might soon enough hear about terminal addiction, at least as a justification in the Benelux countries for psychiatric euthanasia. I don't think that would be a good thing. Um, I guess we could wrap up, Steve. I mean, this has been really great. I have so many more questions for you as a psychiatrist, but also, as I said, I've been thinking about this issue for a while, and I still don't have a fully formed, strong position either way. I'm really compelled by all of the things we brought up that seem to push us to be very cautious at the very least about this. The fact that capacity is difficult to disentangle from a mental health condition, and the worries about treatment and long-term, the longitudinal aspects of mental illness and terminality, and the equity issues, I think, and the access to mental health care issues. I think let's just like end on that question because I do believe that is a major source of we hear about diseases and deaths of despair, right? And many individuals dying by suicide because they're suffering with addiction or various other medical conditions that make their lives miserable. And you sort of have a society that has all of these problems that drive these really devastating conditions. Loneliness, for example, is another thing that seems like it's a real big problem that drives people to feel suicidal. And then we come out and offer an option to die peacefully with a medical professional, and that worries me. I don't know that you can say to people, well, the social structures are bad. You have to keep suffering because our social. But on the other hand, I don't want to. I wouldn't want to see any policies that sort of perpetuate or almost like encourage the social structures to remain the same, which I worry that will happen. And just a quick side note here, a good friend of mine who's a psychiatrist in Canada and is a supervisor for a few of these ACT teams, assertive community treatment teams, has said in Canada when the legislation passed that would allow non-terminal patients with psychiatric conditions to access euthanasia, some of his clients opted out of treatment and they thought, well, you know what? It's not really that helpful and I'd rather just die than live with somebody visiting my house constantly and telling me what to do. So on the one hand, we lack certain structures that would help people access medical care and psychiatric care. And this, I think creates a big gap in the justification for psychiatric MAID or euthanasia. When I say MAID, I should have defined that term. It's medical assistance in dying, um, MAID. So you've got that on the one hand, and then on the other hand, you've got the problem of when maybe a policy passes in a country like Canada, which, by the way, did pass the policy, but then postponed its implementation due to controversy and concerns. But when a country does in fact initiate or pass legislation that would allow for psychiatric euthanasia, what effect do you think that has on patients who are in treatment? Do you think it undermines their hope? Or do you think it gives them a feeling of, okay, at least I have an out, and now I feel like less sort of worried? And I think that second point is what we do see sometimes in Oregon, where and in the other states where there is physician assisted suicide, um, where a patient might get a prescription for a lethal dose of medication, but not use it. They just have it, and they know it's their out if they need it. So it's an interesting problem, where you might almost tacitly encourage patients to um, think about their treatment in a different way, and maybe either lose hope or potentially feel like, okay, I have a fallback and let's keep going.
Yeah, well, as you said, as we wrap up here, you now introduce a whole other really interesting wrinkle. Uh, I think it's an example of how you've really represented the complexity, the richness and complexity of these considerations. And as you say, the implications for the person who might be considering a decision like this, the health professionals who might be involved in helping with making that decision, impact on others around them, whether it's family, friends, loved ones, or even strangers who are, as you say, becoming aware that this is an option, and how that uh, affects, their attitudes towards treatment and their long-term uh, sense of optimism or pessimism or reassurance that they have a trapdoor if they want it, or whatever it might be. And then also implications more broadly for society. What does it say about us as a society as these frameworks become more prevalent? And so I really want to thank you for having this conversation with me today. As we promised, we weren't going to answer these questions, but I think what you've really underscored is the importance of having thoughtful, well-trained professionals involved in the making of these decisions and in the crafting of these policies, the risks of there not being thorough assessments of capacity for those who might make these decisions. And also, as this is the end of our first episode of Medical Ethics Unpacked, it makes me really excited about future conversations to come, because it's really helpful for me as a clinician to hear from you with your expertise as a bioethicist of how to at least start to think through these really complex issues, because ultimately these are situations that clinicians face pretty commonly, whether
Mhm.
it's the exact thing we're talking about or another ethical dilemma for which it's really helpful to have some kind of framework in place to even think about approaching it.
Yeah, I thanks, Steve. I really enjoyed this. I will say we can I'll post some of the references that I mentioned, so viewers and listeners can check those out and read them on their own, because there is a really rich literature in the bioethics literature around this question, and I'd want to be sure that folks can go back to the primary literature and read those papers. But yeah, this is a super complex topic, and it kind of touches on many of the sort of fundamental questions in medical ethics, whether it's around autonomy and capacity or just the value of human life. These are really fun, foundational philosophical questions as well. And so it was really fun having the chance to kind of talk about these with you, Steve, and I'm looking forward to our next episode.
Thanks, Tom. So, everyone, I thank you if you've stuck with us over this past hour, and please join us for the next episode of Medical Ethics Unpacked.